Hello everyone, my name is Dr. Urzola, for the ones who don't know me yet, and thank you for being here in this Facebook call conference. And I am here with Dr. Masís, who is one of my two anesthesiologists, and he's going to be explaining to you some things regarding pain control and anesthesia. So I leave you here with Dr. Masís, who I've been working with for the last 10 years, and I've known him for a little over 20 years. So here, Dr. Masís with you.
Hello, good afternoon, ladies. As Dr. Urzola said, I'm Dr. Masís. I've been an attending anesthesiologist for over 10 years. I've been working with Dr. Urzola ever since we started together. I work at a state hospital, a big hospital, and with Dr. Urzola, I have a fair good amount of anesthesias, over 7,000. And well, I'm here to talk with you and to be able to answer as much questions as we can for all the doubts that you might have. Where can I start? Well, the anesthesia process requires a lot of preparation, of course. We have to interrogate the patient, know about their history, what medications they take, if there are any allergies, any known other diseases that require treatment. I know that most of you are trying to find a relief for your symptoms, are taking also other medications that may not be FDA approved, you know, like ginseng and some other roots and some other things. Some of those medications also have interactions with the anesthesia medicines, so I have to know all about that so we can do a proper plan of the anesthesia that we're going to give to each and separate patient. I try to make your experience as good as possible, although I know that when you're here in the OR, you're scared and you're nervous, of course. But we've been trying to do our best to serve you well. I'm not going to go into the process of putting the patient under anesthesia because I think it's not relevant for this. What is very relevant is the other medications that we use, trying to control your post-op symptoms and trying to get you to feel better after the surgery. Okay. One of the things that we do is that all the patients receive, the minute they go into the OR, they receive a shot of midazolam, which will make you feel a little bit more pleasant. It's a benzodiazepine, and will make you forget. It'll give you amnesia, so you won't remember that. But I've had a couple of patients that before going to the OR told me that they had never, on their previous surgery experience, they had never seen the OR, and chances are that they did, but they were given this benzodiazepine in advance. So try to make you have a better experience. We're going to implement this and give you the benzodiazepine in advance, so when you come to the OR, you're going to be conscious, but you won't remember this because some of you might be nervous or not feeling very well. During the surgery, while Dr. Urzola is performing the surgery, I'm every single minute of the procedure I'm there. I'm taking care of you. I'm watching all your vital signs. I'm making sure that you have a proper level of anesthesia, that you won't remember anything, that you will be pain free, that you have the proper relaxation. And I'm also giving you different medications on your IV line to keep you pain-free, to keep you nausea-free, and to keep you from feeling bad when you wake up. I'm also giving you, well, you get, all of you get, unless you're allergic to, you all get morphine, a good morphine dose in the OR, and the dose of some other anti-inflammatory drugs that maybe I don't think that they use very much in the States. I've asked some patients and they don't know the names, but they're excellent drugs. And I give you a couple of medicines for you not to vomit. You get a shot of dexamethasone that acts centrally, and also another anti-H1 receptor medication called dimenhydrinate, and you also get another one called ondansetron, which is a 4 milligram dose, and you get all this IV so that when you wake up you're feeling fine and you don't have nausea. Now also for pain control, you get medication during the surgery, and you get medication for after the surgery. All of the patients that have already come before, they have experience, they know about the elastomeric pump, which is a silicone pump that it's maybe something like this, but it's completely cylindrical. We fill it up with the medication that you're going to get, and it infuses it into your vein for a 24-hour period. And that, with a couple of shots of extra morphine that you can get on your IV line. You don't have to be pricked again, that you get on your IV line. And for most of the patients, I know that it has been enough. Although if another patient is experiencing pain a little bit, well, we can try, if they tell us, we can try, and of course try to make that better. Now, of course, I want you to remember that it's a big surgery with big incisions, so it's not possible to not feel any discomfort at all, like if you didn't have the surgery. Because a couple of patients have made a comment that they had a little bit of pain and that the experience wasn't so good. We try to do our best, but you have to keep in mind that it's hard to control the pain after it's a big surgery, what Dr. Urzola has to do on these patients. Most of you might have what's called incidental pain, which would be if you're resting, you're feeling fine, but if you have to get up and go to the bathroom, you have to mobilize yourself, then you're going to feel a little bit of discomfort. That's normal after surgery. So I don't know. I think I can answer some questions if you might have. I don't know if I can read. Hello, always. I'm hypothermic. Oh, sorry. Let me see. I always am hypothermic after surgery. Is this due to anesthesia? Yes, it is due to anesthesia. Well, the OR has to be at 18 degrees Celsius or a little bit lower. I know you're thinking Fahrenheit, but it has to be cold. Why? Because the low temperature inhibits the bacterial growth and reproduction, so it brings down the risk of infection. So it's a requirement. Now, the anesthetic gas that we use throughout surgery produces a shift in the blood on your veins, and it pulls it towards the circumference and takes it away from your core of your body. So it makes you lose a little bit of heat. Now, in order to prevent this, we have different things. The IV saline solution that we use is it's at a warm temperature. We have also a convective heater that it's placed between the sheets that blows hot air into your bodies and on the outside of your bodies while you're there, and we of course we keep a thermometer in the OR placed to your body, so we know the temperature that you're having. But it's usual to lose 1 or 2 degrees of your body heat during surgery, and that's why you shake when you wake up and why you feel so cold. It's a normal experience. Dr. Masís, can you explain to us why do we not get narcotic pills after surgery? Okay, I don't know if maybe you could maybe write what narcotics specifically you're talking about, because I know that some of you have a complex pain syndrome, and some of you take hydrocodone or oxycodone or hydromorphone and some other presentations of oral opioids. Specifically with the patients that are not opioid naive, like some of you, it's very hard to control the pain because you are already used to taking these opioids for your pain. So mixing opioids, it's not a good idea because you don't get the benefits of the analgesia, but you do get the side effects of maybe feeling nauseated or feeling dizzy or having a low blood pressure. I think that would answer the question. What pain was in the pump? That's Caitlin Page. Caitlin, in the elastomeric IV pump for post-op analgesia, what you get is the enantiomer, which is dexketoprophene, and metamizole, which here is called lisalgil. Those are all NSAIDs, non-steroidal anti-inflammatory drugs. You get that. You don't get an IV infusion, for example, of morphine, because at the very beginning we tried that, but it makes the patients very nauseated after surgery, so we stopped using that. But you do get 2 shots that are programmed for specific hours after surgery that you take with you when you go back to the recovery. Let me see. Lisha Brown, do you offer monitored anesthesia care? Yes, of course. I recently had surgery and they used primarily propofol. I woke up feeling great, no nausea. When I had great anesthesia, I woke up terrible. Okay. All right, Lisha. We use propofol, of course. All the drugs that you have in the States, most of them we have here, the originals. We do use propofol for the induction of the anesthesia, but the maintenance is done with what's called sevoflurane, which is a halogenated drug. It's the gas. Depending on if there was a specific patient with specific characteristics, we might use only propofol, but it's not the preferred or the most reliable method. It's a long surgery. It's a long surgery. We can't infuse too much volume. There's a lot of volume shift. Actually, I'm glad that I'm talking about this. There is a big shift in your body volumes when you have to get the liposuction. So because you have to get a solution injected in the areas where you're going to get the liposuction, and then they have to do the lipo, of course, and absorb what they can of the fat tissue from there and some of that fluid that was infused. And I have to give you IV medications and IV fluids throughout surgery. So doing an anesthesia with only propofol, which is it's plausible, it wouldn't be recommendable because it's more volume adding to your IV, to your systemic circulation, and I have to deal with everything. So let me see, Ms. Dietrich, if we have medicine, we have to take times daily. How do we take the medicine in the morning? Would it be okay to take it with 1 ounce of water? Okay. Well, we usually ask of you to send us all the medications that you are taking, prescribed or not prescribed, and the secretary gives it to me, and I take a look at it, and I tell them to tell the patient, write an email and tell them you have to stop this 1 week in advance or 3 days in advance, or stop this completely now, and other medications you can keep on taking up until the day of surgery. See, if you have thyroid problems, you have diabetes, if you have high blood pressure or whatever other disease that requires treatment, of course you have to take them. I don't tell you to stop them, of course. Let me see. Have you ever needed to intubate patient with a laryngeal mask versus regular endotracheal tube? Well, yeah, that decision I do right there in the OR, depending on if you're going to get only the explant and the mastopexy, the breast lift, or if you also are going to get the liposuction. Because if you're going to get the liposuction to collect the fat and do the fat graft, you need to be placed usually upside down, and it's not recommended by the American Society of Anesthesiologists to ventilate the patient upside down with a laryngeal mask airway, so those patients always get a endotracheal tube. See, it's a great concern. Well, I trained here in Costa Rica. I also did some training in the States. There are many ways to give anesthesia, and not just because we do it sometimes a little bit differently doesn't mean that it's wrong. As I was talking about before with the narcotics, they interfere with the other medications that I give you in the OR, so that's why we don't give them. Now, if you are already accustomed to taking them because you've had previous pain and you've been managing your pain with this, you can absolutely continue these medications after surgery. I'll just let you know in the proper schedule that you will have to take them, but it's just a matter of a small conversation when I'm interviewing you. Did you need to paralyze us prior to intubation? Yes, Caitlin. The surgery. I mean, the anesthesia requires muscle relaxants, so I can intubate with an endotracheal tube. Yes, it's required. Let me see. I'm concerned about pre-op NSAIDs only as well. I had oxycodone for a few days after my surgery recently, and it worked well. I am not on it any longer. Would you prescribe this for me for a few days if, let me see, if requested? Yes, we can do that. We have oxycodone here as well. We can prescribe that. I don't know if you have any other questions. Let me see. See you there, but one time. But that won't touch the pain. I'm sorry, I don't understand that. Down with it. It was enough for a lot of us. Wait, it was enough for a lot of us. It depends on a lot of factors. Yes, Sherry, it definitely depends on a lot of factors. Some patients require more pain medication after surgery and some others don't. It's just a matter of the pain threshold that you have, which varies from patient to patient. You're absolutely right. It was plenty for me. I didn't need any pain meds after 2 days. Excellent. That's a great experience for you, Amanda. Holly Davis says, you say you stay with us the whole time, so our oxygen and heart is constantly monitored. Yes, I am monitoring throughout the whole procedure in the OR, all your vital signs, your blood rate, your oxygen saturation, your pulse oximetry, the EKG, your blood pressure, how much urine output do you have, the depth of the anesthesia, the relaxation level that you have, the antiemetic level of medications for you not to feel nauseated after surgery, everything. It's over 25 parameters that I have to monitor throughout the whole procedure. I'm there. I can't leave. Can you explain at all about nerve block that allows for less anesthesia and much less pain? Okay, but the nerve block that would depend on what part of the body is going to be operated upon. For this procedure, if you're going to get a lipo from your back, your tummy, your inner thighs, your outer thighs, it will have to be a spinal anesthesia, not a block, because you can't block all those different peripheral nerves. So that's why we usually go for the general anesthesia. But we can have a spinal anesthesia depending, but it wouldn't be an analgesia for your breasts, because then you would have to put a nerve block very high, and that comes with some risk that we don't want to take. How long after surgery can we expect on average to be in recovery before we... How long after surgery can we expect on average to be in recovery before we leave for Chatica? Yes. I usually have you stay there for 90 minutes, and that's plenty of time to see how you're feeling, that you're pain-free, that you're not vomiting, that you didn't develop a hematoma in any of the places where the surgery was performed. So that's about the proper time, 90 minutes. I didn't need any pain meds after either. Okay, it was my first major surgery, beside implant, of course. Whatever you guys did, it felt great. Thank you, Caitlin. Are you mixing lidocaine or something similar into the solution Dr. Urzola injects to the lipo area for pain management? Yes, Marlena. The solution requires lidocaine and epinephrine. The lidocaine is to have the effect of numbness in the area that's going to be used for the liposuction, and the epinephrine is used for producing vasoconstriction, which diminishes the caliber of the small capillaries and reduces the blood loss of the liposuction. Holly says, this is the most reassuring part. The anesthesia to me is most important. We come out alive. Please encourage all women to tell you of their past experiences with anesthesia and all meds. Yes, of course, Holly, we do this. We have an interview and we talk about the whole medical history that you have, and we make the decisions right there upon interrogation. One thing about the narcotics here is that they're sold in not in small blisters of 10 pills, for example. They're sold on big bottles of a lot of pills, so they're expensive, and there's a lot more medication that you actually need. So I see that this is a recurring topic. Okay. Let me see. Caitlin asks again, are you related to Dr. Urzola? You guys look alike. No, we're not related. We're just very, very, very good friends, but we are not related. Okay, how long have you been practicing? We've been practicing together for 10 years now. I have to say, okay, Claire Weinheimer says, I have to say my experience was incredible, especially post-op. I was uncomfortable but not in major pain, and the pain pump was just enough. I was completely coherent coming up out of surgery and wasn't nauseous, which was amazing. Thank you, Claire. If there was a what-if occurrence during surgery, would we be able to be taken straight to the hospital? Example, heart stop, suppressed breathing or something. Okay, well, I'm your guy. I'm the expert in airway. I am the expert in these things. Should any complication occur, I'm the one who has to take you out of it. This clinic has everything that you need should that emergency happen, but if anything would be greater than what we can manage here, yes, we can of course put you in an ambulance and to be taken to a bigger institution, but that would be very, very, very rare. For something like that to happen, you would have to develop an allergy to a medication that you didn't know that you were allergic to, or you would have to have a big heart condition or something that would put you in a higher risk, and we don't take unnecessary risks with patients. We do all the pre-op with the labs and the EKG and everything, and we are sure that the surgery that we're going to perform is perfectly good for each patient. What are your thoughts, Dr. Urzola, about all this? Doctors telling us all that it's all in our mind. What would you tell them? Okay, well, Tracy, I'm not Dr. Urzola, but I don't think that it's all in your mind at all. I mean, if you say that you feel bad, I believe you. If you say that you have symptoms, I believe you. And you just have to see the other patients when they get their implants removed, how they start feeling immediately better. So I would never think that this is all in your mind, never. Okay, let me see. Okay, ladies. Okay, that's Hope saying. I think we have lots of ladies waiting to ask Dr. Urzola questions. Okay, let me see. Shauna Krusky says, I had a great experience too. Woke up clear and like I had just blinked and no nausea. Thank you. Okay, Shauna, excellent. Perfect. Okay, guys, so I hope that this was enough for you to get all your doubts. We're going to be waiting for you here, and I'm sure you're all going to have a great experience from here. Thank you. Bye-bye.
Okay, I'm back here. So I imagine that you have a lot of questions, and the main purpose of this conference is to answer your questions. So we can start with any questions you have. I'm happy to answer them. Hello, Caitlin. How are you? So I see a lot of you are joining in, and well, you know, any questions that you might have, I'm very happy to answer. Um, Leisha says that we are naturals on the live feed stuff, and I have to tell you, it's a lot less stressful to operate than to do this. But thank you. Okay, Shawana asks that if we have had good success with the second fat transfers, if this first one do not take. Okay, this is a very interesting question, and actually, when this technique of fat transfer was first, introduced for breast reconstruction, I was around there. It was Sidney Coleman who started doing reconstructions with fat transfers, and it's not such an old technique. I started doing this during my stage in my last year of training in the European Institute of Oncology in Italy. I think I've told this to many patients. It's one of the flagships for breast reconstruction worldwide, and most of the times we needed to do second fat transfers because these patients had cancer, so we had to do major surgery to remove the cancer, and we had to do second fat transfers or even third fat transfers because they were also getting radiotherapy. So basically, to go over it again, the better conditions you have of the recipient tissues, the better the uptake of the fat. When we are doing block resection, which is a pretty large surgery, we have to create a very big dead space when we remove the implant, and then a pocket is left there. So, we don't have the ideal conditions, okay, to do a fat transfer in many patients because they don't have enough fat tissue or glandular tissue of their own for us to put the fat in there. So, and also many patients have the implants under the muscle, so I can't use the retropectoral space to do the fat transfers. When we have patients who have the implants under the gland, then we can use the retropectoral space, and the fat takes better, because we have more tissue. So it depends very much on the tissue characteristics of each patient. And then when we do a second fat transfer, the possibility of it taking can be better in some cases, but it also depends a lot on how strong your fat cells are, on the technique that is used to do the fat transfer. As I've explained many times to patients, sometimes transferring fat from a place to another is like transferring, plants. Sometimes they survive, sometimes they don't. But normally, when you do a second time fat transfer, you also have more fat from the first fat transfer, so they tend to have, a pretty good uptake. Can I have another question? Let me see. Okay, Dr. Yu, many have asked to see my pre and post photos since I didn't have implants before, and many are wondering why mine was such a success. I have shared individually with some as to how you are able to at times to psychologically inject in different areas, inject in different areas on different people. Would love if you could explain to them how it is different from person to person, and how much where you can you inject. Okay, variability from an individual to another individual is gigantic. There are so many factors involved in this, type of surgery, that is very, very hard to be able to explain, to everyone the individuality of each patient. But I will try to use my latest analogy, which is the fish tank analogy. So if you have a fish tank, okay, and you have a pump, the pump infuses oxygen into the water so that the fish can survive. The more fish you have in your fish tank, the less concentration of oxygen is available in water, and the harder time they have to breathe, and some of them might die if they don't have enough oxygen. Some fish might be stronger to smaller quantities of oxygen, and some others might be more, sensitive. So the ones that are more sensitive die faster. Okay, so this is basically what happens with the tissues. We have a set amount of vessels in your tissues, and they are the ones that bring oxygen to the tissues. Okay, so this oxygen has to be divided between the cells that are there, okay, and the cells that I am transferring. So if the pump stops in the fish tank, then all the fish die, okay. So of course, I mean, we need to have a very, very smart correlation between the amount of fat that I can inject and the amount of fat that will survive. If you do some research in literature, okay, most of the series that are published currently in journals refer to successful fat transfer with amounts that are all under 200 cc's. Okay, 200 cc's is a very small, amount of tissue. Okay, and of course, if I only transfer 200 cc's, the likeliness of these 200 cc's surviving is much better because they have a higher pressure of oxygen. We are trying to do big reconstructions because most of the patients completely, have a very little fat tissue of their own or very large breast implants, okay? And this is where it becomes very tricky. So this is why I started developing this technique of the little cannula so that I can distribute a very large amount of volume in many different areas, okay? It's a very time-consuming process, okay? And, it has to be very well performed, but, it renders better results. The average fat transfers that I am doing are over what is published in literature as, successful rates. And even there, we're getting pretty good success. It is very important that, and now I'm registering and recording the amount of tissue that you have, because many patients have told me, Dr. Urzola, I lost all my fat. And then I show them how little breast tissue they had, and their opinion changes when they see the volume that they actually kept. So it's very important to know that we're trying to go a little bit extreme on the amount of fat that we're doing so that I can please you with a better, volume and nicer looking breasts. Yeah, I'm getting here my ears pulled by Hope, who says that those questions are for Monday. Sorry. Have you any idea of stem cell approval you are waiting may come through? It is looking closer to the end of the year. Well, the stem cell law has already been approved last November. It was a 3.5 to 4 year process, but it is finally approved, and we have already done some stem cell treatments already with fat transfer and PRP. So we are currently doing this, and we are soon opening the Regenerative Medicine Institute, and I can tell you all that the Harvard University and Harvard Medical Center and Dana-Farber Cancer Center in Harvard University has joined our research. So that happened last week, and we are very happy. We'll probably have the office ready like in around 2 or 3 months. Okay, doctor, what are you going to do for us? What are you going to do to make a difference in this life-concerning women with breast implant illness? Will you try to make a major change in the world if insurance authorizing and recognizing breast implant illness? How extensive will your research go, and how quickly will this be? Okay, we are really trying to, get this going. It's very hard for me to be able to answer everyone immediately. It's a lot of you, and I also have my Costa Rican patients. We have been working with Dr. Brenes and the rest of the doctors involved. Our meetings are at 10 p.m. sometimes, and we have been doing a very big research. Again, as I said before, I have a meeting with the breast implant company officials next week, and we really are, going to publish this paper. I am very committed to this problem, and I'm really trying to do my very best to get this paper published. Of course, it's going to take time because we need, an important amount of patients so that this data has statistical significance. But we're working very hard, and we really hope that we can provide you with a published paper in a recognized journal, and start to generate a lot of awareness, because I really think it's very unfair that some of you are not being taken seriously with this. You don't need to be angry at your doctors. You need to understand this is something very new, and doctors are trained in a way in which they need to add up symptoms to give a diagnosis. Okay, and if something doesn't really exist, it's very hard for someone who doesn't have the knowledge to be able to understand exactly what's going on. But we will get there very soon. I'm very positive. I'm very sure of this. And you are very important in this. You are the only ones that can give us the information to be able to publish something that is honest and objective and with scientific relevance. Okay, Dr. Urzola, can you please tell us who is in the OR with you and what role they play in our surgeries? Okay, this is a very important question, and I'm glad that it was asked. Okay, all the personnel that is in the OR is trained and has been working with me for a long time already. Most of the scrub nurses have been working with me since the very start of my practice 10 years ago. Dr. Masís and Dr. Morera are the anesthesiologists that I work with. We have established a protocol that we are improving. We're always learning, and from your feedback, we're trying to be better. Dr. Andres Tapia, who's a board-certified plastic surgeon and who's also my cousin, has been coming to see some of the surgeries because they're very interested in learning what this is all about. So is Dr. Brenes, who is a first-year resident. They are both very interested in learning about breast implant illness, the techniques that I am using, and they have agreed to help us analyzing the data. It's a lot of work to do this. Writing these protocols takes a lot of time, and analyzing this data is very complicated. So I'm getting these doctors acquainted. I'm going to be presenting this in a conference we have soon here in Costa Rica to let the other plastic surgeons be aware of this. It is very important for you patients to know that nobody touches my patients but me. The patients who've come here before, know that it is me even doing the stitches. We don't have OR assistants like they do in the States. It's against the law in Costa Rica. If I am your surgeon, I'm the only one by law bound to doing the nip and all the sutures, the cutting, the design of the surgeries. So you can all be very, very sure that nobody else is touching you and nobody else is doing your procedures, okay? Because I have some patients who've told me, oh, my scars don't exactly look the same, so I'm concerned that you did one side and somebody else did the other one. This is against the regulations in Costa Rica. Assisting doctors or assisting scrub nurses separate the tissues so that we can be more efficient while we're doing the surgery. Remember, we're working inside a pocket to remove an implant that is attached to the ribs. So I need somebody separating so that I can do this more efficiently. And this is the job in which my assistants are involved. Scars are, very, very different in everyone, As I have explained, I have patients who I have done tummy tucks to with a long scar, and part of it is nice, then another part is not nice, and then another part is nice, and then another part is not nice, and this is because the scars are never exactly the same, even in the same individual. So this is something that is important for you to know. Since this question arose, I have decided to start registering more of the surgery. Now I'm asking them to record me doing the sutures and record me doing the initial part of the procedures. Just as now we are handing everyone a list of drugs with the indications and what the drugs are used for, and we're taking pictures of these documents. Since the very beginning, I have had a policy of full transparency with the patients. This is why I record all these clips during the surgery, and I show you that I do the en-bloc. So I have started to do this with the sutures also, so that you can all be 100% sure that it is me the one working and doing these procedures. Teamwork is very important, you know. The people that I have in my OR are people that I really trust, that are extraordinary professionals, and that are people that are committed to patients and to giving a very high quality of service to patients. They're all very compassionate people that I really trust. Really, we're trying to have a very, very transparent process. It's very hard to record the full procedure because, I mean, we would need like a mega server to do this. It's a lot of data, but you know, I want you all to be 100% sure it's only me working on you. Do you feel the rib cage is altered in shape by implants, making potential breast appear small? Sorry, the question moved. Smaller. What I don't think it's the shape of the thorax, but what happens is many times, and you can see this in the videos after the explantations, the capsules contract the prosthesis and make it smaller, and then when you cut the implant out, you know, you see that the implant is actually larger. So this gives an image of a smaller implant or lesser volume with a bigger implant. And I have done many videos where I have both explants there with the blocks, and when I cut one open, you can see that the implant looks a lot larger than the one next to it. But then when I cut the second one open, the other one is as large as the first implant. So it's mostly the capsule that's contracting, you know, the implant and giving less volume. The other thing is that many patients don't have the information on the prosthesis as they had, or they think they had smaller prosthesis as they really had, or larger prosthesis than they really had. So these are mainly the factors. Do you feel for mastectomy patients with very little breast fat, and the fat and the implant is under the muscle, what helps get the fat to stay? Additionally, there must be extra fat inserted to fill the volume. Is a good result realistic with one fat transfer? It is going to depend on mastectomy patients on many different factors. This is what I started when I started getting involved with fat transfers to the breast, was exactly for cancer patients. And it is going to be very relative to the type of treatment you got. If you had a full mastectomy plus radiotherapy or many radiotherapy treatments, if you had an intraoperative radiotherapy treatment only in monodoses, if you had a quadrantectomy or a full mastectomy, you know, it is going to depend very much on the skin quality that you have. If you developed or not radiodermitis, radiotherapy creates a vascular desert, so there's less blood supply, and sometimes you need to keep on doing more and more fat transfers. When the retropectoral space is available and there's muscle available, then the fat transfers take better. Most cancer centers nowadays preserve the pectoralis major muscle, but sometimes the pectoralis major muscle needs to be amputated. So you know, each case has to be analyzed on a single basis to give you a better answer for that. You know, can you explain to us why plastic surgeons get paid? Sorry, the question left. Can you explain the healing process? Okay, that is a very important question from Caitlin Page. I am going to start sending all the patients, and maybe I can send it to someone in the Facebook group and it can be shared with everyone. A scarring process is a very long process, okay? we are now dealing with different types of healing processes. Okay, we're dealing with one related to the scars themselves, which is a process that sometimes can take even years. You know, there are several stages to scarring that take place. You know, there is an initial phase of inflammation, there's a contraction phase, there's a resolution phase, there's a remodeling phase. You know, so all these phases that are related to the scarring process take time to evolve, and you are going to notice, which is another thing that I'm going to start doing now, is I'm going to start taking pictures of how the scars look immediately after surgery, okay, so you can compare them, because many times scars tend to widen a little bit, they tend to become red for a period of time, you know, and it might take, you know, sometimes even a couple of years for a scar to completely fade and become into a white line. This also varies from individual to individual. Some people do very nice scars, some other people do hypertrophic scars, some other people do keloid scars, you know, so it depends very much on the scarring process of every individual, but it is standard and it is to be expected that scars during the first year are not as nice, and then after the first year they start to improve, you know, and to fade away, and the redness or the brown of the scar, depending on your skin type and skin color, starts to fade away after the first year. In most cases, sometimes it might take a little longer. The other thing that's very important is related to fat necrosis, which is also part of the healing process. Fat necrosis is going to be an ongoing process for, the resolution, of fat necrosis is going to be an ongoing process for years, you know. Just like when you had your breast implants placed and you could touch the margins of the implants in many cases, especially the thin patients, you know. When you inject fat, you know, lumps will be created. It's the normal inflammatory response of the body, okay, and this, you know, will generate fibrosis, which is scar tissue. Some of the fat cells that we inject will die, and it has been one of the major concerns of patients. Am I going to have problems with breast cancer diagnosis? There's many papers already published, and again, these techniques were born in cancer centers. The calcifications are very different to breast cancer calcifications, so a trained radiologist should be able to tell the difference between them. So you should expect to feel lumps, okay, for, you know, quite a long amount of time, okay. Don't be afraid, you know. You don't need to be doing a mammogram every 6 months, you know. Just know your breast like you do with BSE, you know, breast self-examination, and know to learn where your lumps are, and if they are becoming bigger, then you should consult. But the likeliness is, as time goes by and the body's mechanisms, you know, start to, you know, to eat this, you know, fat necrosis, cells called macrophages do this, these lumps will tend to become smaller. It's a process might take even years. I am worried about scars being high up on the breast and on the underside. Is there a way to keep the scar in the crease? Okay, very important question from Tailina. Thank you for that question. It's one of the hardest things, you know, when you do, you know, and block resections with fat transfers in the same procedure. Why? Well, because we have when you do a breast lift with an implant, okay, you have a fixed volume that is not going to change, okay? So you can mold the skin around that fixed volume that is going to be completely, you know, stable in time. With fat, this changes, you know. So if I design your breast lift to be, you know, for a certain volume, and then this volume diminishes a little in time, of course the scar is going to vary, you know, in placing, okay? And in these cases, the only way to fix it is to do further fat transfer to recreate the volume, and then the scars will go to where they were, you know, supposed to be, or to move the scar a little up to, you know, fix it to the new volume. Doctor, do you believe that being pregnant with a child while having implants that are creating mass toxins in your system affects the child long term or even short term? much like a woman who smokes or does drugs or drinks while pregnant, not just to include breastfeeding, but actually growing inside the mother from the mother. Well, honestly speaking, that is an answer that I don't have, I mean, that's a question I don't have an objective answer for. The studies have proven that there shouldn't be any problem with breastfeeding with breast implants. I mean, many babies are born completely normal with moms that have breast implants, and even several babies have been born with moms that had breast implants and they're being breastfed. So I don't know if there will eventually find there's a correlation. So far, there's no scientific data that's been published that links any sort of problems for babies with moms with breast implants. I mean, things might change, but so far there's no data regarding that. Many have expressed that they wished more fat had been taken from a particular area, or feel like they didn't even have lipo. Could you share your decision process on how much and where you take the lipo? Okay, this is a very good question from Kalina. Thank you for your question. In the process of doing an explant surgery with reconstruction in a single time, my major concern, is to do the blocker section. So that is really what I am most worried about. The second concern is because again, we're doing this in block process because patients are sick, so we're trying to heal them, the best we can. The second thing that is very important, is to generate a good aesthetic result, for your breasts. And for this, we need the fat, because many of you have such large breast implants or such little breast tissue that if we don't do a fat transfer, you're going to be, left with almost a flat chest, By the same token, some of you are not really good candidates for liposuction. I have been performing liposuctions in some people who I would have never done a liposuction to if it was not because I needed the fat for the volume. So when deciding on where to do liposuctions, many of you can testify that I have told you that you are not a good candidate for liposuction in your abdomen because your skin is too saggy. Patients that are over 60 years old have a lot less contraction potential. Patients that are younger have much better contraction potential, so the results tend to be better. Patients who have stretch marks are not good candidates. Patients who have a lot of obesity are not good candidates. Liposuction is not a technique to lose weight, but to shape, and to give better contour. Like for instance, liposuctions in the thigh areas are very, very difficult because we are dealing with gravity and with skin that has very little contraction potential. So sometimes I am forced not to remove so much liposuction from an area because otherwise the skin is going to sag too much, and then the result is going to be more poor or worse than if I take less, fat. So sometimes I really regret having done liposuctions in patients that I even explained very clearly that they were not a good candidate to have liposuction, say, in the abdomen, and then they were telling me, Dr. Urzola, I didn't get what I was expecting, and I'm like, well, I told you that you were not a good candidate, So this is something that I am going to start being more clear with, because, our major concern is to be able to get fat so you're not completely flat-chested, right? So this is something that has to be taken into consideration. Some of the patients are not good candidates for liposuction, and I'm just trying to do my very best to obtain the best result that I can, And again, it happened with a patient where she told me, oh, but you did a liposuction to someone who had a similar abdomen, and then you didn't do it to me. The reason for which I didn't do this liposuction to this particular patient is because she was not a good candidate, and the other patient had better skin quality and was younger and so she qualified. I mean, I'm really trying to do my best to give you the best possible result in a really complicated surgery to perform with a lot of factors that are out of our control. Okay, so I'm getting here the information that we have to stop now, and if you can join us for more questions on fat transfers on Monday. So I hope this was good for you. We will have all these questions. I'm going to do my very best, to answer all these questions. Again, anything that you need, please call us. I want to apologize very much for not getting back to you immediately sometimes. I really try to do my best to do it within the first 24 hours. But, it's a lot of patience, and I do very long hours. So sometimes it's hard. So please be a little patient, and I'll keep on trying to do my best. So I wish you all well, and may God bless you all. Have a great Saturday evening. Thank you.